The outward signs of elite cardiovascular fitness are undeniable. The resting heart rate sits in the low 40s. The VO2 max is exceptionally high. The training log reflects hundreds of hours of perfectly executed physical output. Then the routine blood panel comes back. Despite all that work, LDL cholesterol, the metric associated with arterial plaque, is alarmingly high. For an endurance athlete, this creates a very specific, immediate fear. If you accept a prescription for a statin to manage that cholesterol, you risk chemically dampening the athletic engine you've spent years building. You worry you'll lose your aerobic edge, your power, and your physical snap. The medical reality is straightforward. Decades of meta-analyses show that lowering LDL cholesterol reliably reduces the risk of heart attacks and strokes, even in people who are otherwise considered low risk. The math heavily favors intervention. So the objective shouldn't be a blanket refusal or a blind acceptance of medication. The goal is to design a targeted strategy that drives your lipids down to a safer level while fiercely protecting how you feel and perform on race day. Standard lipid panels measuring total, LDL, and HDL mass are often too vague to be useful for athletes. Lean, highly trained individuals frequently have lipid mass numbers that do not accurately reflect the actual quantity of dangerous particles in their blood. This chart compares standard LDL measurement to an ApoB particle count. ApoB is a protein attached to every plaque-building cholesterol particle. Tracking ApoB counts the exact number of dangerous particles. For an athlete, this provides a far more accurate assessment of actual cardiovascular risk. If your clinic cannot run an ApoB test, looking at non-HDL cholesterol is a highly effective secondary option. It calculates all the cholesterol that isn't HDL, capturing the total atherogenic burden. Demanding an ApoB or non-HDL measurement is step one. You cannot accurately weigh the risk to your athletic performance if you are making decisions based on the wrong biological target. Massive training volume does not grant you immunity from strong genetic factors, nor does it cancel out a fueling strategy heavy in saturated fats, like butter, coconut oil, or high-fat dairy. The American Heart Association establishes clear scientific guidance here. Emphasize whole grains, legumes, and lean proteins while restricting saturated fat. This remains the baseline requirement for cardiovascular health. For athletes dealing with stubborn lipids, the most effective food-first intervention is a specific dietary pattern known as the portfolio diet. This pattern requires eating specific cholesterol-lowering foods every day, a viscous fiber source like oats or psyllium, tree nuts, plant-based proteins like soy or legumes, and a strict limit on saturated fats and oils. Clinical trials prove the portfolio pattern produces meaningful LDL reductions. However, eating high volumes of fibrous, filling plant matter requires severe dietary discipline, and it directly complicates the high-calorie, easily digestible fueling strategies most endurance athletes rely on. Diet is the mandatory starting point, but athletes need to be objective and recognize when their strictest fueling efforts are mathematically insufficient to break through their genetic cholesterol ceiling. If diet falls short, you arrive at the primary point of friction, the widespread belief that daily statins inherently degrade VO2 max and erode muscular strength. The clinical data tells a different story. The STOMP trial, a placebo-controlled study specifically testing statin effects on muscle function, found that even high doses of atorvastatin over 6 months did not reduce measured exercise performance or muscle strength in healthy users. This chart compares muscle symptom intensity from blinded N-of-1 trials, where patients alternated between statin and placebo. The reported pain levels were virtually identical in both phases, demonstrating a strong nocebo effect. The expectation of side effects often causes people to experience them. But elite performance is highly sensitive. When you are deep into a hard training block, baseline soreness is constant. It becomes incredibly easy to misattribute standard training fatigue to a new medication. And the athlete's lived experience has valid roots. A study of Boston Marathon runners revealed that statin users exhibited higher post-race levels of creatine kinase. Creatine kinase is an enzyme that leaks into the bloodstream when muscle tissue is damaged. Statins do not inherently ruin your baseline fitness, but extreme endurance efforts can legitimately amplify the biological cost of your recovery. Athletes must approach pharmaceutical intervention exactly like a training load, Execute strategically and aim for the minimum effective dose required to trigger an adaptation. This scatter plot maps two athlete-friendly statins. On axis is Pravastatin, highly regarded for its physical tolerability. On the other is Pitavastatin, which achieves strong LDL percentage drops at very low milligram dosages. Selecting these specific formulas allows you to secure a meaningful reduction in ApoB without subjecting your system to the massive chemical loads associated with default high-intensity prescriptions. For athletes highly prone to muscle symptoms, alternate day dosing is a practical clinical hack. Taking the medication every other day allows for recovery windows while maintaining a consistent downward pressure on lipid levels. Be aware that alternate day dosing lacks definitive long-term cardiovascular outcome data. If you use this approach, you must treat it like an experiment and run frequent blood panels to verify it is actually suppressing your ApoB. Reject the one-size-fits-all approach. By utilizing microdosing and targeted compound selection, you can safely thread the needle between clearing your arteries and preserving your muscular tolerance. For athletes dealing with severe familial hypercholesterolemia or absolute intolerance to statins, there is an advanced intervention, PCSK9 inhibitors like evolocumab. These injectables operate entirely outside the traditional statin pathway. They bind to specific proteins in the liver, allowing your body to clear atherogenic particles out of the bloodstream at a massive, accelerated rate. There is a notable nuance here. The Fourier trial proved these injectables radically lower LDL, but they do not alter a marker called hsCRP. hsCRP is a standard blood test used to measure systemic inflammation. The medication suppresses lipids directly without changing your underlying inflammatory baseline. PCSK9 inhibitors are heavy-handed for mild cases, but for athletes with extreme risk profiles, they serve as an unparalleled, muscle-sparing lifeline to achieve total lipid suppression. This decision tree outlines 3 distinct paths, allowing you to match the exact intervention to your specific biological risk profile. Path 1 is for the optimizer. If your overall cardiovascular risk is low, execute a strict 6 to 12-week portfolio diet block. Treat it like a training camp, follow the parameters flawlessly, and retest your ApoB. Path 2 is for the performance anxious. If you hold moderate risk and require medication, work with your clinician to establish a minimum effective dose of Pravastatin or Pitavastatin, potentially on an alternate day schedule. Path 3 is for the high-risk athlete. If you require secondary prevention for a prior heart event or have severe genetic disease, bypass the diet experimentation. Push immediately for potent statins or PCSK9 inhibitors. Prioritize your vascular survival. Whichever path you take, stop tracking your side effects based on intuition. Measure your response against stable, objective metrics, a repeatable heart rate to power relationship, or daily HRV. HRV stands for heart rate variability, a reliable metric used to measure physical recovery capacity. And follow one strict logistical rule: never initiate a new lipid-lowering medication during the final build-up to an A race. Test the variables when the stakes are low. Accurately identifying your risk profile dictates precisely how much energy you should expend on dietary discipline versus advanced pharmacology, stripping the fear entirely out of the process. A flawless training log and low resting heart rate do not grant automatic cardiovascular immunity. Spending hours a day optimizing your physical engine is ultimately pointless if the vascular system responsible for delivering oxygen to it is slowly deteriorating. With precise ApoB tracking, disciplined dietary blocks, and highly strategic microdosed pharmacology, a loss in athletic performance is an avoidable variable, not a guaranteed life sentence. You do not have to make a permanent choice between a long, healthy life and a fast race. By applying the right scientific playbook, you can